Actually, by talking about something that may be completely unrelated, just to get our heads all in the same spot. I know we're from different fields, all related to eye health, but we might have different roles within our organizations and different organizations entirely. So I wanted to start out with something that I think is fairly human, and that's chocolate. So one question I have for all of you, I'm looking for your just shouting out to me, how do we get chocolate? What does it require to make chocolate? Does anyone know? I hear cocoa, cocoa milk, sugar. Sugar's a really key ingredient. Yeah, so we need some things to actually have the chocolate bar. We can't just buy chocolate. It has to come from somewhere and be manufactured. And so if we think about that, milk, sugar, and cocoa, now we can ask ourselves, how do we get those things? Where does milk come from? Cows. I grew up in the state of Wisconsin in the U.S., and it is the dairy state. So I'm very glad that we have cows, that everyone realized that one. Where do we get sugar from? Sugar cane. And what about cocoa pods? It's a tree, a cocoa tree. Right? So all of these things come from somewhere. And even with something like cows, they're not just existing, right? We need some infrastructure, some equipment maybe. It's a little more industrialized for the U.S. They have actually large farms with cows and milking machines. So that's all required. The food to grow the cows. For sugar, similar process, right? We go through the harvesting process to cut and burn those fields, to refine the sugar, to transport it to the chocolate factory. And for cocoa, this is a very large supply chain coming from all around the world, but we have cocoa trees which need also to be harvested and dried, right? So this is a big process. This is all the upstream stuff that comes into the factory to make chocolate in and of itself. So there's a process then within that factory when they're making the chocolate. They mix things, they grind things, they mix some more. There's all these machines that go into making chocolate, and eventually we get the chocolate that we want. So the next question, now that we have kind of the upstream, what happens downstream? What do we get after eating chocolate? I hear energy. Anything else? So we get some energy from that chocolate bar, but usually the chocolate doesn't just come to us as chocolate. There's a wrapper, so we get some garbage, and our body doesn't just absorb all of that chocolate bar. We'll also get some waste in that sense as well. But these are all parts of that chocolate process. So if we look downstream, right, there's all these other things that go into packaging that chocolate and getting it to your hand. So the factory will wrap up and package and deliver those things to you. You'll use them. And then hopefully that solid waste from the chocolate bar, the cardboard and the wrapper, will end up in some sort of waste treatment. Although, we do see a lot of garbage on the streets here. So that could be an issue. But landfilling is usually what happens. And then we have wastewater as well, which is hopefully also being treated. So this is all part of what I think of as the life cycle of chocolate. We have upstream, we have downstream, all these different steps and stages to get chocolate to our hands so that we can enjoy it. And the same is true with pretty much every product, every process that exists. The chairs you're sitting on, the hospital you're sitting in, and the services that are provided in this hospital all have life cycles. And there's different ways to think about this. You could think of patients coming through the hospital, right? Each step that patient has to go through to get their eye care delivered. I think about it in terms of products, that there's all these products that need to be produced and delivered so that we can provide eye care, and then something has to happen to all those products afterwards as well. This is a life cycle. This is the first step in Lifecycle Assessment, where we actually are quantifying the environmental emissions at each step and stage in this process. So the question now, we'll get some more shout-outs, is how do we provide cataract surgery? So I'm hoping a lot of you are familiar with cataract surgery enough to offer me some suggestions. What things do we need, similar to the milk, sugar, and cocoa, what things do we need to provide cataract surgery? Energy, infrastructure, so we need a building, and an energy source, staff, human resources, patient, we do need patients to provide eye surgery. That's a big one. Probably the most important one with the cataract, right? It's preferable that they actually have cataracts. So we have energy, building, patients, human resources, right? We need people to help support that whole system. Equipment, consumables. So equipment might be the phacoemulsifier if that's the approach you're using, maybe a heart monitor or something else like that. And then you have all these different supplies. Anything else? Transportation, so patients still have to get there. Packaging, all your supplies have to get there safely. Lots of energy. All of these things require energy. Okay, so that's a good synopsis of all the things needed for cataract surgery. That's how I started approaching it when I had done the carbon footprint of cataract surgery here at Aravind, was to think about all the things that are needed to go into that system and then to start measuring what we could measure. And so our supplies are all coming from somewhere. This is a facility for Medline, if you're familiar with that manufacturer. This is where they create disposable custom packs. So all these different supplies, you can see a basin here and some what we call blue wrap, it's plastic sheets. These are all manufactured all throughout the world, India, China, Thailand. They come into the US, they're packaged up for individual surgeries and sent to that hospital. They're opened up, used, and thrown away. But every single one of those has to pass through a bunch of people's hands to get here. They're all manufactured, they're all packaged, they're all transported. And then after we use them, at least in the US, we landfill them. So this is a landfill on the border of Ohio and Pennsylvania. I used to work fairly close to here. And if we zoom into this section, first off, you'll notice there's some farm fields nearby to this landfill, and the landfill is pretty large. If we zoom in, we can see the large trucks delivering the garbage. This is where our medical waste goes. This is actually where the hospital where I worked deposits their medical waste. So this is physical, it's tangible. All these things come from somewhere and end up somewhere. And in the case of the US, we use these supplies once, if we're lucky. Sometimes we open up the package and hardly use anything, but we still have to throw everything away. So all these steps and stages create emissions. All these steps and stages require energy, usually water as well. And life cycle assessment adds up all those different things into a single unit, like a carbon footprint, like a water footprint, like the cumulative energy demand. So what we're measuring with environmental sustainability are all those emissions at all those steps and stages. So the life cycle assessment, this is the formal definition. We're quantifying the environmental impact of a product or system. It's a scientific approach, so it helps us prevent greenwashing. So you've probably been into a store and seen something that was organic or natural or green, and unless we know the environmental emissions, that could be a complete lie. That maybe it was made out of something natural, but technically everything on this planet came from something on this planet, so the claim is not very effective. But with life cycle assessment, we can compare different products, compare different systems. We can look in detail at our system and find where the environmental emissions are coming from. So it's a very effective tool to actually measure sustainability. So again, this is just a different representation of the life cycle, right? We have raw materials are extracted from our earth. They're transported to places where they're manufactured, transported to places where they're used. We might reuse some of those things, and ultimately we'll end up throwing them away. So one thing you'll notice about human products' life cycles is that they're not very cyclical. It's a very linear system. It starts at one point and it ends on another, and we don't have a lot of feedback. It's just pure waste. So life cycle assessment says at each and every one of these stages we have some inputs of materials and energy, and we have outputs, waste. Every step generates garbage. Every step generates emissions. And so life cycle assessment takes all of those different things, collapses them down into a single number. And usually we actually have a lot of databases to help us, right? So I didn't come here to Aravind with greenhouse gas collector to measure how much was being emitted. I had a database of information that said for 1 kilogram of plastic, this is the amount of gases that are generated. So it's an estimate, but it gives us a good idea of how much is being emitted when we're doing cataract surgery, for all the supplies that are needed for that cataract surgery. So everyone on board with that? Does that make sense? It's a high-level overview of how carbon footprinting and life cycle assessment works. There's a lot of challenges with this. It can be very involved. It takes a lot of time to go through step by step and count each thing. And so that's one of the challenges I'm trying to overcome in developing new tools to help anyone do these kinds of footprinting. We can do it off of the quantity of materials, so kilograms and volume, and we can do it off of the price of materials, although that's a little less accurate. It's easier because we already know the price of all of these things. So again, we have this carbon footprint of cataract surgery out of the UK. We keep talking about this. It's because there's not that many studies out there. And so this was kind of one of the first ones to look in detail at cataract surgery. I've personally done some studies looking at hysterectomy, so gynecological procedures, birth procedures for obstetrics. We've been starting to look at orthopedic surgeries as well. So basically, surgeries are a really fascinating area because operating theaters use so much energy and so much resources relative to other areas in the hospital. So this has received a little bit more focus than other areas, but again, there's not that much data out there. And again, we see this particular element with our 500 kilograms versus 25, or kilometers, sorry. And I just wanted to point out the different categories again, right? So we went through waste, we measured all the waste. We went through procurement, measured all of the supplies that were being used, all of the pharmaceuticals that are being used, and we estimated the energy usage. Right, so we had to go through the hospital and look at each one of these inputs and see exactly how much was being put into this system. And so that's kind of the first step in understanding or in developing your carbon footprint, is just knowing what's being used. And so if you don't have the resources to do a full carbon footprint, there are actually steps, precursor steps, that would be just as relevant. So how much waste are you generating? How much energy do you consume? And that can be a good starting point for developing different sustainability initiatives within your organization. I think this applies to sustainability just as much as healthcare. An ounce of prevention is worth a pound of cure. The more that we can do to reduce our needs, right, if it's energy consumption or materials and supplies, that's stuff we're not even having manufactured. Not needed, it's far better than needing it and trying to recycle it. So that's where you should really start, is with that efficiency approach. So what do? I'm going to walk through a few generic steps because, again, we're a fairly diverse audience. So hopefully this will help all of you start coming up with your own ideas for your own organizations. The first goal is really to set those priorities. What do you want to accomplish within your organization? Where do you focus your green energies? You can look at the clinical side. That's the area I like because it's a fascinating tangle of regulation and policy and personal preference and all kinds of cool things. But of course, with healthcare, there's a large non-clinical area as well, with the energy that's provided, with transportation and food services and all kinds of things. You might look at just facilities or utilities, depending on where you're located, what they're called, the infrastructure that's providing your framework for care. But you might also look at, say, supplies or the process and more of the operations. How can you internally be more efficient with the services that you're providing? And another question you have to ask yourself is, where do you have influence personally? So you may be the chief medical officer of your hospital, where you probably have a lot more influence over the total policy and mission of the organization. Or you might be a mid-level ophthalmic professional, right? A nurse in the OR who's providing supplies to the surgeon. You still have influence, but the sphere of it is a little bit different, right? So you can tell your surgical team, hey, I don't think we should open supplies unless we know we need them. Or maybe we should turn off the lights when we leave, right? Little things like that can still make a big difference. So the first step in setting your priorities is really understanding where you can make changes, where you have the influence and power to do so. And then also looking at the structure of your organization. So where are the good leverage points to make the kinds of changes you want to make? So those are important considerations. And then you have to have the ideas. So where do you start? A workshop like this is a very good place. Hopefully you'll get lots of ideas over the next couple of days. I always love talking to people who have a different background from me. So I'm an engineer, and engineers are interesting people. They're wonderful people, but they also tend to forget that people are people, and the systems that they design are for people. So it's nice to be able to work with clinicians of all different types, to work with administrators. It's especially important when I'm looking at sustainability. I can see where there might be higher levels of emissions, right? I can say, oh man, this piece of equipment is using so much energy, there's so much carbon emitted there, but I'm not a clinician. I can't say, get rid of it, it'll be fine. I need someone's advice, professional advice and thoughts to make the right kinds of decisions. And so that interdisciplinary teamwork is absolutely crucial. So within a medical facility, particularly in clinical areas, you really want to have a large group of people involved in any kind of major changes. That can include infection control, right? You still want things to be safe, and so having that expert opinion is crucial. There's obviously going to be regulations, so having people who are well-versed in the laws of the area are good. For us, we have not just clinicians, but kind of pharmacy and supply chain, waste management, building services. All of these groups should be involved in that decision-making, and indeed can generate a lot of really interesting decisions and ideas. So colleagues and peers are a really great area. We see this in a tool called Lean and Six Sigma, that we're usually asking people at all levels of the facility to generate ideas on how to become more efficient, because the people who are doing those things day to day know what needs to be done. And so, people you might not think of, housekeepers, might have really great ideas for how to make things more sustainable and more effective. And so it's good to hear all those different voices when you're making decisions. And then literature. As an academic, I will always tout the literature. There are a few good studies out there. Good to read through some of those reports and books and other things to get ideas of what other facilities have been doing to increase their sustainability. So we have our very excellent paper on cataract surgery at Aravind. There are books generically speaking about healthcare sustainability, and there's also really great forums and other resources out there to generate ideas. To talk a little bit about what I learned here at Aravind while I was working, some of the things that they've done to be more efficient and to deliver more sustainable care. One, I think, has to do with the physical layout. So in answering that question earlier, how do we reduce the footprint of phacoemulsification? One thing is to think about how patients are moving through that space, right? So can you get more patients through in a faster time period is the question. And one of the answers might be, where are patients getting stuck? Where does it take a really long time for a patient to get through where we're not providing service? It's not an added value to the patient. They're just waiting. And the physical layout can do something with this. So this is, I believe, the operating theaters in Madurai. They have chairs set up outside the operating room, so the surgeon's never waiting for a patient to come through. The patients might wait a little bit at each step and stage, but there's always a patient ready for that high-value action the surgeon provides. And the physical layout is designed as such that the patients can really flow through that system easily. Task shifting is kind of another big one. So what jobs does each person in that facility have? In the U.S., the physician usually will greet the patient when they arrive in the preoperative area. They'll talk to them a little bit. They'll go into the OR with them, do the operation, and follow them out after the surgery. And it takes a lot of time. That's part of the reason why a surgery in the U.S. takes a half hour to an hour, is the surgeon isn't just operating. They're escorting the patient through the system. Well, kind of nice for the patient, perhaps, is not the best use of the surgeon's time. Their skill set is really that surgical period. And so task shifting is one of the approaches that Aravind has taken to make sure that surgeons are trained to do and patients can flow through that system more easily. So it's basically saying some of these tasks should be shifted onto employees, mid-level ophthalmic professionals and others who are not trained necessarily for the surgery but could help with the process. Standardization, I think, is another huge one. I think Aravind has done this very well, where most of the surgeons do kind of exactly the same procedure with exactly the same supplies. Standardization, we found in medicine, can lead to much better outcomes. There's lots of examples of this. A hospital outside of Toronto in Canada that does only hernia repairs. And because it's very standardized, they have very excellent outcomes for hernia repairs. And I think that's part of the reason that Aravind has such excellent outcomes. It's because their surgeons, their clinical teams have a lot of practice doing standardized cataract surgeries. So there's very few surprises. What that does on the supply chain side is it says we can purchase things in bulk. We know exactly how much we're going to use. There's not that much variability. So the waste isn't there. Whereas in the US, we see surgeons who use just half of a custom pack and throw all of the rest of the supplies out, even though they were never used. So it generates a lot of extra cost if you're not standardizing. And then designing the system so that you're reducing your waste and maximizing reuse. Again, this is that reduce, reuse, recycle concept. It's a reason it's phrased that way. You start with reduction, lead to reuse, and then recycling. That's the order that's most effective for the environment and indeed for pocketbooks as well. I will talk a little bit more about drug waste later on, but in the US we waste a lot of drugs. And if there's a way to get rid of that before reusing, that's one of the best steps that we can go on. And of course, maintaining safety. This is crucial because if you're not providing safe and effective care, then what's the point of doing it at all? If you're not doing something right, that is in itself a pure waste. So waste of an opportunity, waste of all those resources that went into it. If it's not quality care, don't bother. So those are some of the strategies I think that Aravind has enacted to create a much more sustainable model of care than we have, for example, in the UK with the carbon footprinting. So once you have some of these ideas, once you know what types of things you want to tackle in your service, then you have to start implementing those changes. And so this is where I think we have some challenges on the sustainability end of the spectrum. We need to supply better tools so that you can monitor progress. The idea is that you want to pilot interventions, right? You don't want to do broad sweeping things initially. You want to make sure that they work before you roll them out across your whole organization. But you want to energize people. I'm trying to energize you now. It's good to have people energized and excited about these activities. More people will be on board. They'll be more likely to report any issues so you can solve problems early. You want to observe what's happening. You want to measure what's happening. That is absolutely crucial. And to record those things and to repeat the cycle as many times as needed to get that sustainability intervention successful. So here's a look at some operating rooms in the US. We use a lot of disposable supplies, and one of the issues that I saw when I was observing cases there was the waste of drugs. And without doing a full life cycle assessment, we just asked the simple question, how much are we wasting? And we don't really know, right? So they're partially used bottles of supplies. And so what I had done with a team of students was to basically go through and measure some of these things. So this is just solid waste from a bunch of different facilities across the US, and then of course we have Aravind, unsurprisingly a very tiny amount of waste. And what you'll notice here is that there's very little recycling in the US. There's only one facility we saw that did recycle, and there's a decent amount of variability in how much waste is generated between these different sites. So these are all interesting things that we noticed just when we started weighing the garbage of each case. We started looking at the supply costs. And again, Aravind's looking pretty nice on supply costs. But across the US, we saw a lot of variability. The IOLs were fairly standardized, so that one didn't show up. But pharmaceuticals, we're spending a lot of money on drugs in our cataract surgeries. And supplies will show up, and there's a lot of variability you can see in the supply costs for providing the same phacoemulsification, basically. So we wanted to look at those drugs in particular, and the students that I had sat in the ORs, and after each case, they weighed the amount of drugs that were left over, that were intended to be thrown out. And the interesting find for us was that for eye drops, 95% of those eye drops by weight were being thrown away. This is a huge waste. We have shortages of dilating drops in clinics, and from operating rooms, we're just throwing away literally liters of this. This costs a lot of money as well. So in one of the facilities where we were working, that had a particularly high wastage rate. It was something around $25,000 a month being thrown away in drugs, just for cataract surgeries. We didn't look at the other eye procedures. So a lot of waste, there's a lot of reasons for this waste, and that's the next steps for us, is picking that apart and saying, where can we make changes? Is it all policy related? Can we do some reuse? Can we buy different size drops so we're not throwing out so much of it? And this is where having that interdisciplinary team has been very helpful for me, having people who know regulatory compliance, infection control, and the clinical aspects. We can start developing solutions to address at least one small problem in our cataract surgeries. But every place is different. One thing I tell my students in sustainability all the time when they ask, what should we do? What's better? The answer is always, unfortunately, it depends. So you have to look at your system. You have to know what's happening there, how much energy, resources, whatever else you're using, and you have to make decisions for your own location. We all love magic pills. I think the wonder of cataract surgery is that it is kind of magical. You can take blindness and cure it. That's amazing. Unfortunately, the work for sustainable healthcare is a little bit harder. You have to work individually on each of your own problems to come up with your own solutions there. But by sharing our ideas, I think it'll be easier for us to generate those ideas and also to push policy to make it easier across the board. And so that's kind of what's happening in sustainability and eye care that I'm aware of. One thing you'll also have to note when you're working on these things, there will be barriers. There will be obstacles and challenges as you're trying to implement sustainability. So it helps to basically look at the root cause, right? Why can't we do this? Why can't we reuse our eye drops? And then to ask the next why when it's, well, there's regulations. Why are there regulations? Well, it's an infection risk. Why is it an infection risk? And then you might discover they haven't actually done any data. They don't have data to support that it's a risk. It's a perceived risk. So then you have to start asking more whys. And so that root cause analysis, the 5 whys, is a really good way to dig into the problem, to understand where it's coming from and how you might address that source. You also should think about the costs. So sustainability often goes hand in hand with cost savings, though not always. So you do have to think about the total cost of items. This is particularly true with reusable versus disposable supplies, right? There's a total cost of ownership. And reusable supplies may look cheaper, disposable supplies may look cheaper on a one-off basis, but if you look over the lifespan, many years of using reusable versus disposable supplies, that could shift. And so these are different ways of kind of looking at it, right? Most people just look at this price. What's the price I'm paying for this item? Total cost of ownership looks at that fuller life cycle to say, hey, if I'm responsible for purchasing through disposal, I have to account for all those costs. I have to pay to dispose of this item. How much is that total cost? And then we get more into the kind of environmental or social impacts when we look at life cycle costs. So the full life cycle chain, what are all the expenses? What are some other costs, environmental costs like carbon footprint? And then looking more fully at all of those different impacts, water, energy, carbon, et cetera. So the broader you can go in looking at your impact and your costs, the better decisions you'll be able to make. So easy approaches, just to get us thinking about what might happen. This is a little bit geared towards the US, but monitoring what you're wasting is a good place to start. You all probably have access to scales and other things like that, so you can measure it. What are you wasting? And that will help you really pin down what activities you might want to enact. Working with your whole department to standardize things, this can be a big challenge. A lot of physicians in the US don't like having their professional opinions taken away from them in essence. So this is a delicate balance. But if you can standardize things, it goes a long way towards improving things at your organization. Improving patient throughput, right? Can you use the same resources you're using now to see more patients? There are usually ways to do that in most organizations. So to think about that, partnering with supply chains to ask about these total costs, to ask about emissions. A lot of manufacturers actually do life cycle assessments internally. They might not report what their carbon footprint is per product, but sometimes they actually know that information. So you could just start asking. It's a good way to get the discussion going and to help buyers know that you're interested in these issues. And looking into alternative disposal options, right? Composting, recycling, reuse, what options are available instead of just landfilling. Harder approaches, right? Redesigning your process entirely. Instead of just putting Band-Aids on it, can you redo the whole thing so it's more efficient from the start? Can you help change policies? So for us in the US, this is, can we send antibiotics home with the patient? We're not allowed to do that right now, so those drugs the patient has to buy twice, and we throw out one huge bottle. It's very frustrating, but those are the policy shifts we're looking into, and that will obviously vary by location. And then, of course, pressuring suppliers and manufacturers, can they provide better products, more efficient eco-emulsifiers or any other kinds of equipment and tools? And I think those are well worth the effort, though a little bit more challenging to enact. So that's all I have for the moment, but hopefully that's given you more ideas on how life cycle assessment works.